This video is part 2 of the health assessment video. It will mainly focus in on lab values. Other topics discussed in the health assessment chapter of the PMHNP Review and Resource Manual are disease prevention activities and gender-based medical testing and screening and health behavior guidelines, among other topics, and those will be discussed in part 3. So this is going to be part 2 of the health assessment chapter recap, and it does include personal notes and variations. So it's not strictly out of the book. There are my own variations incorporated into these notes. The electrolytes I'm going to be discussing are calcium, sodium, magnesium, chloride, and potassium. Other values I like to include and also try to commit to memory are the following. Sodium 135 to 145, potassium 3.3 to 4.5, chloride is 100 to 110, CO2 21 to 25, urea nitrogen 5 to 20, creatinine is 0.5 to 1, BUN creatinine ratio 5 to 20, and glucose 75 to 100. In my slides, in the slide deck under the section for potassium, I labeled it as 3 to 5. So simply just for ease of memorization. So that's why I have that there, and I think I have chloride at 90 to 100 versus what you see there. As far as the basic BMP, I'm going to talk about calcium 8 to 10, and then other values to commit to memory are anion gap 5 to 15, and the GFR should be greater than 60%. Electrolytes are carried out as a part of routine screening in acute and critical illnesses, or where there's a known or suspected disorder associated with fluid, electrolyte, or acid-based imbalance. Calcium. Calcium abnormal values less than 7 are associated with tetany, greater than 11 are associated with hyperparathyroidism, and very high calcium at levels greater than 13.5 are associated with metastatic cancer and hypercalcemic coma. Most calcium, 99% of it, is located in the bone, and the remainder is in the plasma and body cells. Of the calcium in the plasma, 50% is bound to the plasma proteins and 40% is free or ionized in the ionized form. The remaining fraction circulates in the blood. Calcium is the major cation for the structure of bones and teeth. The functions are the enzymatic cofactor for blood clotting, required for hormone secretion, required for function of the cell receptors, required for plasma membrane stability and permeability, and required for the transmission of nerve impulses and the contraction of muscles. Calcium balance is mediated by interactions among 3 hormones: parathyroid hormone, vitamin D, and calcitonin. Acting together, these substances determine the amount of dietary calcium absorbed and the renal reabsorption and excretion of calcium by the kidney. Medications that affect calcium levels. So an increased calcium level could be caused by excessive milk ingestion, lithium use, thiazide diuretics, vitamin D, and alkaline antacids. Decreased calcium levels could be caused by anticonvulsants, aspirin, calcitonin, corticosteroids, heparin, laxatives, diuretics, albuterol, and oral contraceptives. Values are higher in children because of growth and active bone formation. Conditions that can increase calcium levels are acidosis, hyperthyroidism, cancers, and Addison's disease. High calcium or hypercalcemia is higher than 12, and systemic effects are weaker fatigue, lethargic behavioral changes, impaired renal function, bradycardia, shortened QT interval, or depressed T waves. Decreased calcium levels can result from alkalosis, hypoparathyroidism, renal failure, pancreatitis, insufficient calcium and or vitamin D intake. Low calcium or hypocalcemia, lower than 8, systemic effects are neuromuscular excitability, convulsions, hyperreflexia, severe muscle spasms, tetany, prolonged QT interval, and paresthesia. Now we're going to move on to sodium. Sodium normal values are generally 135 to 145. Sodium accounts for 90% of the extracellular fluid cations and is the most powerful cation in the extracellular fluid. Sodium regulates osmolality, which is interstitial and intravascular fluid volume. Sodium works with potassium and calcium to maintain neuromuscular irritability for conduction of nerve impulses. Sodium regulates acid-base balance. It participates in cellular chemical reactions and membrane transport, and it regulates renal retention and excretion of water. Sodium maintains systemic blood pressure. Factors that decrease sodium level are Addison's, renal disorder, GI fluid loss, and diuresis as far as conditions. Medications that decrease sodium levels are lithium, vasopressin, and diuretics. Sodium increase can be caused by hypovolemia, dehydration, diabetes insipidus, excess salt ingestion, gastroenteritis, and drugs that can increase sodium are adrenocorticosteroids, methyl-dopa, hydralazine, and cough medication. Systemic effects of hypo and hypernatremia. Hyponatremia are lethargy, jugular venous distension, decreased urine output, confusion, apprehension, and coma. And hypernatremia is restlessness, low risk for jugular venous distension, fever, and thirst. Common to both hypo and hypernatremia are hypotension, tachycardia, and seizures/convulsions. Now we're going to move on to magnesium. Magnesium normal levels, according to the Purple Book, it's 1.3 to 2.1. For the sake of this review and memorizing it in a little bit easier, I'm going to label this as just 1 to 2. Magnesium levels 1 to 2. Magnesium is a major intracellular cation. 40 to 60% is stored in the bone and muscle. The kidney is a primary regulator of magnesium. Low levels of magnesium are caused by renal conservation, a cofactor in intracellular enzymatic reactions, and it is a cause of neuromuscular excitability. So magnesium is a cause of neuromuscular excitability. Magnesium interfering factors. Factors that increase magnesium levels are antacids, laxatives containing magnesium, salicylates, and lithium. For decreased magnesium, factors that decrease magnesium are thiazide diuretics, calcium gluconate, insulin, amphotericin B, neomycin, aldosterone, and ethanol. Factors that increase magnesium, so a level higher than 2, are Addison's, adrenalectomy, renal failure, dehydration, hypo and hyperthyroidism, and diabetic ketoacidosis. High magnesium levels greater than 2 or 2.5, systemic effects are nausea and vomiting, muscle weakness, respiratory depression, decreased skeletal muscle contraction, hypotension, and bradycardia. Low magnesium levels, or lower than 1 or 1.5, could be caused by hypokalemia, malnutrition, DKA, alcoholism, acute pancreatitis, GI loss from vomiting, diarrhea, nasogastric suctioning, or fistula, malabsorption syndrome, or pregnancy-induced hypertension. Low magnesium levels, lower than 1 or lower than 1.5, systemic effects are depression, confusion, irritability, muscle weakness, increased reflexes, nystagmus, tetany, ataxia, and convulsions. So, low magnesium levels, depression, confusion, irritability, muscle weakness, and increased reflexes. Chloride normal values, in the Purple Book, it's 98 to 106. For the purpose of better remembering these values, I'm going to remember chloride at a normal value of 90 to 100. Chloride is a major anion in the extracellular fluid. It provides electroneutrality in relation to sodium. Transport of chloride is a passive and follows the active transport of sodium so that increases or decreases in chloride are proportional to the changes in sodium. Chloride levels higher than 100 can be caused by acidosis, hyperkalemia, hypernatremia, dehydration, renal failure, Cushing syndrome, hyperventilation, and anemia. Chloride levels lower than 90 can be seen in alkalosis, hypokalemia, hyponatremia, overhydration through the process of diluting the chloride, or diuresis, Addison's disease. The medications will be discussed in the next slide, but they are ethacrynic acid, furosemide, thiazide diuretics, and anemia. And increased chloride levels greater than 100 are acidosis, hyperkalemia, hypernatremia, dehydration, drinking too little water, Cushing's syndrome, and the medications are potassium chloride, acetazolamide, methyl dopa, diazoxide, guanethidine, and burns. Chloride interfering factors. Increased chloride levels can be caused by oral intake of potassium chloride, acetazolamide, which is a classic treatment option for glaucoma, as it causes a reduction in aqueous humor. It is also useful for treating altitude sickness because of its underlying mechanism of action. The medication works to excrete bicarbonate. Doing so alkalizes the urine, as there is a greater bicarbonate in the urine. Methyl dopa is a centrally acting sympatholytic agent used in the treatment of hypertension. Diazoxide, also known by the brand name Proglycem, is used to treat low blood sugar, and it works by blocking the release of insulin from the pancreas. Guanethidine is an antihypertensive agent, and the brand name is Ismelin. Then there's decreased chloride can be caused by ethacrynic acid, or brand name Edacrin, and it belongs to a group of medicine called loop diuretics, or water pills. Loop diuretic agents can increase the chloride excretion by 20-fold. Other loop diuretics are bumetidine, which is Bumex, furosemide, which is Lasix, and torsemide, which is Soans, and these are all loop diuretics, which will cause a decrease in chloride levels. Then there's HCTZ, or thiazide diuretics, and a common one is HCTZ, hydrochlorothiazide. And high bicarbonate levels will cause chloride levels to decrease because there's an inverse relationship. False decrease of chloride levels can be seen when in the context of elevated triglyceride or elevated myeloma proteins. There are no specific symptoms for chloride increase or decrease. Potassium normal values are 3 to 5.1. And of course, there's different variations of this, but for me, it's easy to remember 3 to 5. Potassium 3 to 5. Potassium is the major intracellular electrolyte. Total body potassium is about 4,000 MEQs, with most of it located in the cells. Intracellular concentrations of potassium is about 150 to 160 MEQ per liter. And the extracellular concentration of potassium is generally within the values of 3 to 5. So although potassium is the major intracellular electrolyte, the values that we recall regarding potassium levels being 3 to 5 are indicative of the extracellular concentration of potassium. As it is the predominant intracellular ion, potassium regulates intracellular fluid osmolality and provides the balance for intracellular electrical neutrality. Potassium is required for glycogen deposition in the liver and skeletal muscle cells. Potassium maintains resting membrane potential and assists in transmission and conduction of nerve impulses. Potassium maintains a normal cardiac rhythm and skeletal and smooth muscle contraction. Potassium balance is regulated by the kidney, aldosterone levels, insulin secretion, and changes in pH. Increased levels of potassium are seen in acidosis, insulin deficiency, Addison's disease, acute renal failure, hypoaldosteronism, infection, dehydration, and dehydration. Systemic effects of hyperkalemia or higher potassium levels higher than 5 are muscle weakness, paralysis, tingling of lips and fingers, restlessness, and intestinal cramping, diarrhea, and ECG changes, narrow and taller T waves. Mild hyperkalemia has an ECG change of shortened QT interval, and severe hyperkalemia has the ECG change of depressed ST segment, prolonged PR interval, widened QRS complex leading to cardiac arrest. So severe hyperkalemia can lead to cardiac arrest. Decreased potassium levels will be seen in alkalosis, excessive insulin, GI loss, laxative abuse, burns, trauma, surgery, Cushing syndrome, hyperaldosteronism, thyrotoxicosis, anorexia nervosa, and a diet deficient in meat and vegetables. Low potassium, lower than 3, systemic effects are impaired carbohydrate metabolism, impaired renal function, polyuria, polydipsia, skeletal muscle weakness, and smooth muscle atony, cardiac dysrhythmias, paralysis, and respiratory arrest. And those are systemic effects of hypokalemia, so lower than 3. Potassium interfering factors. Increased potassium levels can be caused by amphotericin B, which is an antifungal agent. Other names for that are Ambisome or Abilect. Tetracycline, which is an antibiotic to treat a variety of bacterial infections, including acne. And potassium-sparing diuretics, usually ending in ONE, such as spironolactone, and this will increase potassium. Isoniazid, which is INH, is an antibiotic used to treat tuberculosis, will increase potassium levels. Chronic marijuana use will also increase potassium levels, and acute marijuana use usually will lower potassium levels. Now, decreased potassium levels can be affected by drugs such as ethacrinic acid, which is a loop diuretic, and also in the family of loop diuretics are furosemide, which is Lasix, and bumetanide, which is Bumex. And so ethacrinic acid is a loop diuretic, and it can decrease potassium levels. So can furosemide, which is also a loop diuretic, will decrease potassium levels, and thiazide diuretics, which is HCTZ, will also decrease potassium levels. The end.